Some risks of mechanical ventilation in distributive shock are decreased cardiac output. This is caused by positive pressure ventilation decreasing venous return. Right ventricular dysfunction due to the high levels of PEEP and the underlying respiratory distress, which puts extra strain on the right ventricle. Worsening hypotension and ventilator-induced lung injury due to the high levels of airway pressure. And as always, it's very important when administering mechanical ventilation to keep our risks in mind and adjust ventilator settings to best benefit our patient. And that's all for distributive shock. In my next video, I'll talk about cardiogenic shock. Now let's get into cardiogenic shock. Cardiogenic shock occurs when the heart is suddenly unable to pump enough blood to meet the body's demands. This is typically as a result of a severe myocardial infarction. Some signs and symptoms we'll see in a patient with cardiogenic shock are severe hypotension, tachycardia, shortness of breath, cool and clammy skin, altered mental status, reduced urine output, and chest pain. Some imaging studies used to diagnose cardiogenic shock. The primary one that's used is an echocardiogram because it gives us such a quick visualization of what the heart is doing, and it also can help distinguish between left or right heart failure. An echocardiogram is also great because it can help us identify the underlying cause. So is it a MI or a structural defect, anything like that. That's why an ECG is so beneficial in diagnosing cardiogenic shock. A coronary angiogram looks for blockages and is also a great tool to use because it can allow for immediate treatment through angioplasty. Chest x-rays can help look for pulmonary edema and can look at the heart's size. So in the image below of the chest x-ray, obviously we can see that the heart is extremely enlarged. And finally, left heart catheterization measures pressures and just gives us another visualization of the heart. Pharmacology management in cardiogenic shock focuses on improving cardiac output and restoring good blood pressure. That's where our vasopressors come in, like norepinephrine and dopamine. Inotropes like dopamine help with cardiac output, and milrinone for increasing systemic vascular resistance. And finally, vasopressin, used alongside norepinephrine, can help to increase blood pressure in severe shock cases. Hemodynamics in cardiogenic shock are going to be a low blood pressure with a systolic around 90, a low cardiac output, usually around 2 liters per minute or less, and a low PaO2. Pulmonary capillary wedge pressure is usually going to be high, typically around 15 millimeters of mercury or higher, and this indicates left ventricular failure. CVP is also going to be high, around 10 millimeters of mercury or greater, indicating right ventricular dysfunction. And systemic vascular resistance is also going to be high as a compensatory mechanism. An ABG in a patient in cardiogenic shock is typically going to show a metabolic acidosis due to lactic acid buildup with respiratory compensation. So we're going to have a low pH, low bicarb, and a low CO2 to compensate there. And some indications for mechanical ventilation are going to be severe respiratory distress, usually tachypnea with rates greater than 30 breaths per minute, refractory hypoxemia despite non-invasive support, hemodynamic instability, and flash pulmonary edema. So while mechanical ventilation is often necessary for cardiogenic shock patients, it does pose some risks. Some of these include severe hypotension, reduced cardiac output because of the positive pressure ventilation, failed extubation because of persistent hemodynamic instability, and increased mortality. Studies have actually shown that cardiogenic shock patients that do require mechanical ventilation have an increased mortality rate compared to patients who just use non-invasive measures. And that's all for cardiogenic shock. And lastly, we're going to talk about obstructive shock in our next video. So last but not least, we have obstructive shock. Obstructive shock is a form of circulatory failure caused by physical, non-cardiac, or vascular obstructions, which prevents adequate blood flow to the tissues. Some signs and symptoms of obstructive shock are severe hypotension, tachycardia, jugular vein distension, tachypnea, altered mental status, cool and clammy skin, and low urine output. Imaging studies used to diagnose obstructive shock focus on identifying the underlying cause. So this could be pulmonary embolism, cardiac tamponade, or attention pneumothorax. This is typically done at the bedside through cardiac ultrasound, and I have placed a picture below of an example of an ultrasound of a patient with an obstructive shock. As you can see, there's a large mass in between the left atrium and the aorta. Another important tool used is an echocardiogram or an ECG. ECG can help determine cardiac tamponade, pulmonary embolism, or right ventricular dysfunction. And then we have chest x-ray and finally a CT, which can help to definitively diagnose if the patient has a pulmonary embolism. Pharmacology management in obstructive shock focuses on immediate stabilization with IV fluids, so vasopressors like epinephrine, fluids, so normal saline, and then finally dobutamine to improve myocardial contractility. Hemodynamic monitoring with obstructive shock aims to find the source of the obstruction that's impeding the blood flow. Some of the hemodynamics will look like a low cardiac output, high central venous pressure, and a high pulmonary artery pressure. ABG anomalies, typically the ABG for an obstructive shock patient will be metabolic acidosis due to lactic acid buildup and impaired oxygen delivery. And mixed acid-base disturbances can also be common. Mechanical ventilation indications for patients in obstructive shock would be increased oxygen consumption, respiratory failure, increased work of breathing, and hemodynamic collapse. So let's talk about the risks of mechanical ventilation in obstructive shock. First, we have hemodynamic collapse due to increased intrathoracic pressures, worsening hypotension, reduced cardiac output, and hyperinflation due to high airway resistance because of the obstruction. And that wraps up the last bit of obstructive shock. And finally, to sum it up, we talked about differentiating between each type of shock, what makes them different, and how they compare to each other. We talked about each one specifically, hypovolemic, distributive, cardiogenic, and obstructive shocks, the signs and symptoms, how to diagnose them, and finally some treatment options, mechanical ventilation options, and medications to give. I hope you enjoyed this presentation over hemodynamics and circulatory shock. Thank you.